All right, so let's go through now. Another will be very, I would say, heavily data-driven talk for next 30 minutes. I don't know why they wrote down 20. Uh, I know we are late, but we still have to go through the message. But it does not matter, as you know. My last slide will put everything together. What you need to take home in terms of what we have learned in this. Now let's see. Okay. Oh, so it only can move by this, right? Okay. So just to say, I always start my presentation paying the tribute or thanks to the guy who made it happen, Andreas Grundtvig, who did the father of angioplasty, the first one done in 9/16/77, just with a balloon angioplasty. A dream was catheter-based percutaneous treatment of vascular disease in alert and awake patient. And this is where our live symposium started. That he used to then came to Atlanta. Initially went to San Francisco, then went to Atlanta, where he used to bring all the interventionists in our auditorium situation set up, doing the PCI, everybody watching it. So C1. Then give all the equipment because companies were very limited. So how to make the device, we had to a balloon catheter, the wire, the guide catheter, go back and do one, and then teach one. So C1, do one, teach one started with Andreas Grundtvig. And how things have happened, and I'm sure up in the heaven, he's sitting, must be seeing it, that how safe it is. His third case was a trouble, went for open heart surgery, and after fifth case, he was let go from his place because complications started happening with the balloon angioplasty. The key is now it's safe. Like our complication, less than 1%, 30-day event, and less than 5% at 1 year. Second, appropriate, we want to do that it's going to benefit patients. We have the guidelines called Appropriate Use Criteria, AUC, guidelines of the ACC/NC DR, and that basically tells you that you do where it makes sense, not just by doing that there is a blockage, you take care. So that's why we go a lot of physiological testing, imaging testings, and so. And then lastly, ambulatory. As you know, the 60% are same-day discharge, 95% discharge next day. So it really has gone long way from there. And that has happened because of the lot of advances and of the advances of 2025 we are going to talk right now. The first one is mechanical circulatory support in cardiogenic shock trials. So there are few trials which have been the balloon pump, Impella, or CardioHealth, which is ECMO. So these are the three devices have been tried in various settings. The last one, which is the ECLS shock, that is the ECMO, and 30-day, and then they have the 1-year data showing no benefit of using ECMO in cardiogenic shock. So we say many of the maybe patient will go home early and recovery will be different. None. So totally no benefit of ECMO in cardiogenic shock. Then we have a trial which took a long time to complete, danger shock, both done in the Denmark and Germany, about 360 patients use Impella, which is called microaxial flow pump versus standard of care, and followed these patients, and basically finally we found a real device which decreased the mortality by 13%, 58 to 45.8 in these patients, and benefit started very early, as you can see from that graph. Despite that there were some issues with the device, and those were that higher vascular complication. You can imagine that if your vascular complications goes down, maybe the difference would be even better, will be more. The device at present, Impella is 14 French. We are at present investigating 3 new Impella type devices, which are 9 French. And there, this limb ischemia, bleeding, all will decrease. So benefit could be even bigger in the oncoming. They will be available by end of next year. Then now we have the 10-year follow-up of the danger shock trial, because right from the beginning, it still remain about 16% benefit, and it was in the all group. So just to say that, yes, Impella finally won in the cardiogenic shock. Then the shock caused by the heart failure. This is a balloon pump versus standard of therapy in cardiac shock by the heart failure called L-shock trial, and basically showed again no benefit of balloon pump. So negative ECMO, negative balloon pump, plus Impella, and you can see that more bleeding and other event rate with the balloon pump and so. So that led to the guidelines that microaxial intravascular flow pump is still is 2A in patient with STEMI and refractory or cardiac shock. It hasn't made it to 1 yet, but I'm sure with updated guidelines it will make, because this was still earlier guidelines than this danger shock trial. And what also has shown is the class 3 is the balloon pump or ECMO in patients with cardiac shock, because it has not shown to be any beneficial. Second point, the immediate versus stage complete revascularization MI trial. Remember, it has been shown that full revascularization in multivessel STEMI is better. Then question was, then their trial showed that whether you do the stage in hospital or outside, at the same time, or you do it in the stage intervention. There were 2 trials were done, and they actually got to the guidelines also. BioVasc showed that immediate complete revascularization was better than stage. Why? Because while patients were waiting, developing unplanned revascularization or MI. 2 trials, and the second trial was the same, multi-stars, again showing the same, that while waiting in the stage group was harmful. Although there was a complete MI trial, did not show much difference in that, but other 2 trials showed. So therefore, now the question was, stage is better, the full revascularization better. Then question is, what if you do it in stage versus you immediately do all of the vessel? At time 0, patient comes in, STEMI, not a cardiac shock, maybe a little heart failure, okay. But if patient comes in, not a shock patient, multivessel disease, do it right on day 1 or you do it in day 3. Stage in hospital revascularization for multivessel. This was a trial done to answer this question. And of course, you can see that imaging was done in about 1/4 of patients, the one immediate group versus second group. There were minor differences, but not much. But most important message is here that immediate revascularization versus delayed stage revascularization, but same hospital admission was not different in overall, except in some subgroup. And what the subgroup was, that patient was in heart failure, elderly patients, and even also multivessel disease. You see that curve more on the right side. So key is patient with heart failure, elderly patient, multivessel disease, don't do all the vessels same time. That is troublesome. So I think this trial, in my opinion, has not changed what we have been doing at present. We always have been doing that, do the culprit vessel, and unless it's a second vessel is looks like 90%, 95% subtotal, very ulcerated lesion, we wait. And then do it after a few weeks. That actually has been the overall practice, and I don't think it's going to change even based on this trial, because same, the patient with heart failure or other, is better to wait anyway. Then the drug-coated balloon. This is a field which has been evolving in last few years in America, while this has been kind of old news for outside USA, because we just got the DCB approved, drug-coated balloon, and many trials, and basically DCB can be used for 2 purposes. One is for the ISR or for the de novo vessel, and ISR basically we already have a stent. So now you prefer not to put another stent, and all the drugs which we used to use for the drug-eluting stent are put on the balloon. The advantage of the DCB is very simple, short DAPT. Patients who are bleeding risk, you don't want to put a second stent, is the right one. And of course, decrease inflammation, less side branch closure, and let's see where we are. What led to the approval of the first drug-coated balloon in America was the Agent DCB of Boston Scientific, and it was single stent was 56.7%, multiple stent was 43%. So majority kind of half and half, you can say, and they compared against balloon angioplasty. The DCB compared against balloon angioplasty for in-stent restenosis, and what did they find? Clearly the benefit, lower TLR, lower target vessel MI, although technical success was identical, individual endpoints were better in the Agent DCB compared to balloon angioplasty, and there was no stent thrombosis because there was no stent. So it looks great. The only problem is that what we do usually when you have the DCB, when DES restenosis, guidelines say DES is class 1. Is recommended over drug-coated balloon for treatment of ISR. Right now, there are few other trials ongoing. One of them will be presented end of this month in the TCT, solution ISR, which is the sirolimus, randomized against the DCB, against the second comparative group where 80% was the DES and 20% was balloon angioplasty. So we'll see that will be a true trial that comparing against the DES, which is what the guidelines are. So we still continue to do a majority of the cases when your ISR of the stent, put a second stent. In some selective cases, we do a drug-coated balloon. One of the limitation also is the reimbursement of the DCB, which is cost is about $5,500, very selected group. It has to be like outpatient, Medicare, some Aetna, they reimburses, otherwise institution loses money on them. Then second question came, what about in the native vessel? Not in the ISR, native vessel using the drug-coated balloon. This is a trial from China using a paclitaxel-coated drug-coated balloon versus Firebird, their sirolimus drug-eluting stent in a simple cases. And what they found, now all of a sudden you see the DES is better than the DCB in the native vessel. In the ISR, DCB better against balloon angioplasty. Now you are doing a native vessel, comparing DCB with the DES, and clearly seems to be that there is an advantage of the re-DES rather than DCB. Now, say, what happened in individual? So we found that in the small vessel, both DCB and DES were identical, but large vessel, real advantage of the DES over DCB. So clearly that a small vessel, maybe you can think about putting the DCB in cases where issue about the antiplatelet therapy, but large vessel clearly should be the re-DES. Then issue is the bifurcation trial. You know, patient have bifurcation lesion. We used to put a 2 stents. There is some issue about in those cases. Some do bad, some don't do that well. So question is, what if you put a drug-coated balloon on the side branch? Again, the trial was done with a DCB bifurcation trial where they compare side branch, not with a stent, just with a balloon angioplasty. So what they found basically, again, the advantage was there. The DCB group did better compared to the non-compliant balloon, but was not compared against the DES in the native vessel. But still you can make it a point. The side branch doesn't have to be that every case you need to put a second stent. The bifurcation lesion side branch drug-coated balloon could be okay. So this is what we do now. Actually, we kind of started doing now because of still limited about because of the reimbursement pattern. But many people do that. If your concept is go away from the DES for some reason, it's reasonable that you having a DCB strategy. But DCB strategy has to be that your lesion has opened nicely by a technique, and your DCB are just putting it as a last stage, kind of coat the lesion with a drug. But lesion has opened nicely. So therefore, you have a lesion preparation with a pre-dilatation, rotational atherectomy, whatever need to be done, and your angiographic results are good. If you want to imaging or physiology, looks good, then it's okay to do the drug-coated balloon. And if not good, then you put a DES. So basically what we are trying to say is the DCB alone is good enough in some cases compared to DES, and particularly cases where we worry about very long lesion, side branch, or patients who have bleeding issue. And what basically are the indication, where would you use DCB, DSISR, a small vessel, side branch, and then high bleeding risk patient where the depth interruption is needed. And we actually have a nice review article in JAMA Cardiology about the DCB because that's at present the DCB use globally varies. In America, it's less than 1%. In UK, it's 32% of the PCI at present are being done with a DCB. So things are changing. Probably will happen in USA. This number will go up over time when we have more drugs will be available. By next year end, we expect at least 3 other DCB preparation will be available, and then the cost will go down. One of the limitations has been now is the cost of the device. Then the next advance is the imaging. So this is actually have been one of the top 10 in last many years, because what has happened is we were trained and we did until, let's say, almost last 10 years, 10, 12 years ago, based on the angiogram, we decided what the lesion was, we treated it, put the stent, be happy, everything fine. Then the whole concept, what if you do additional imaging in the vessel by using the OCT, IVUS, NIRS, to really see whether you have done the good job or completed or optimized it. And that actually had led to the multiple trials of imaging, or called intracoronary imaging or intravascular imaging, IVI or ICI, in every aspect of the vessels have been done, numerous trials, and all have shown consistently benefit of imaging over just angiography. Now, I just take one, the test example of the trial called OCUPy, done from Korea, and basically OCT guided cases, complex lesion, bifurcation, long lesion, and compared to angio guided, and the followed patient for 12 months, and what they found, they have clear-cut criteria that OCT, you have optimized the stent. And they have to go through all optimization, and found basically that OCT guided group decreased the event by 30 to 50% in various aspects as shown here. So clearly OCT guidance was better, was again representation of what has been shown in multiple trials before. And then there was also done with the DCB, the article about the meta-analysis by Greg Stone in Lancet, which put all the trials together until earlier last year in each aspect of our PCI. Target lesion failure with the death, MI and TLR, stent thrombosis, and all individual endpoint on the right side, there is a reduction in event rate anywhere from 20 to 50%. The imaging trial have shown 50% reduction in thrombosis, and of course other endpoints as shown here. So yes, now the question is, should you be doing imaging in every case? Well, that actually we get little help from the guidelines, although in United States, imaging is still done only 22% of cases. At Sinai, we started becoming about 33. And basically, benefit, in my opinion, is mostly in the post, really optimization of the lesion. And the guidelines now support complex bifurcation, left main lesions. Imaging is class 1 indication, not routinely, but imaging. So that could make your 30, 40% of cases, and we are about there now. So both acute coronary syndrome, otherwise complex cases, benefit. So this is, now we started the separate intravascular imaging live, which is the first Friday of every other month, because a lot of interest, and I know with the Huda and of course Kiski, our imaging specialist, and Nitin Barman is the moderator for those. And then, just like we take the risk score, there is a bifurcation risk score came from here by our own database, that 1,800 patients they analyzed with the bifurcation and come up with the score, low, medium, and high score, correlating with based on the various risk factor of the clinical as well as the angiographic risk factor for these patients, and predicting that who will have event-rated follow-up. Then the plaque modification and imaging combined. Modification means that usually what we do a balloon, open the blockage, put a stent. But if you do atherectomy, you do a laser, so all those we call plaque modification or shock wave. So key is the multiple trials have been done comparing OCT, IVUS, and angio guidance in the calcific lesion. As you can see here, OCT, again, little better, lower restenosis, less late loss in the target 3C trial. And then another trial which compare rotational atherectomy, IVL, or laser in calcific lesions. And you can see the second device, many times you need a second device, but overall the trial showed that the laser was not good compared to rotational atherectomy or IVL. IVL and rotational atherectomy were identical. So seems to be in a calcific lesion, the great advantage of rotational atherectomy and IVL to change it. IVL actually have a very low complication, and although the fracture also we caused a little more with the IVL, but laser overall did not show benefit, so calcific lesion, they don't do well. Again, another calcific trial using the OCT showed that by using OCT, you get a better minimum stent area, better stent expansion compared to angiographic alone in this calcific lesion without increasing any complications. Then we have another trial comparing IVL against rotational atherectomy. And basically just to show that there was no difference. So key is consistently in calcific lesions, RA, rotational atherectomy, and IVL are equal, except not every case you can get IVL because bulky rotational atherectomy sometimes is needed before putting the IVL in these cases. Now, what about the rotational atherectomy in ISR? Remember, just like drug-coated balloon. And trial showed actually even harmful, no benefit of the routine rotational atherectomy in ISR patient with this trial. Then there is another device called orbital atherectomy. The rotational atherectomy has a diamond at the tip, and here is entire, there is a special crown, also has the diamond chips, eccentric crown called orbital atherectomy. And this was an Eclipse trial about 2,000 patients comparing orbital atherectomy compared to high pressure balloon dilatation. Conventional angioplasty, some cases were done with a cutting balloon also, basically showed no difference in terms of outcome, in terms of stent expansion, rather slightly higher complication of slow flow and perforation. Except that if you did imaging, then the orbital atherectomy did better compared to balloon angioplasty. Patients who had imaging was done in about 65% of cases, and 70% was OCT, 30% was IVUS. So overall, say again, in calcific lesion, another orbital atherectomy did not work. Laser did not work. RA and IVL both are good. Then next is the depth de-escalation. So there were 5 trials were presented in European Society last month, actually 2 months now, about de-escalation, because we know that stents are so good nowadays. Many times you can stop the therapy within a month, depth, make it single. So many trials have done to identify, and the old trials, I'm just going to show the latest one, which were presented, 4 trials in the European Society of Cardiology. First one was the target first trial. What if patients who are MI but low ischemic risk, the simple, straightforward, don't have a complexity, what if you stop their antiplatelet therapy, make it monotherapy after 1 month in MI and PCI, take away the aspirin, make it a monotherapy, single antiplatelet therapy with the P2Y12 inhibitor, aspirin only, not stopping the clopidogrel it was actually P2Y12, majority of them either were ticagrelor or prasugrel, but stop the aspirin after 1 month. And what did they find? By stopping, you see the ticagrelor was 73%, prasugrel was 22%, small clopidogrel and special stent, and found that stopping it in terms of which is the net adverse cardiac event, were identical. Ischemic difference were no there. More importantly, you had lower bleeding by this. So taking the aspirin in a low risk MI was beneficial rather than continuing. So see how things have come. In one point, very essential, you take a DAPT, had to be strict. Now, you take away aspirin, after 1 month, nothing happened. Was okay. Then there was the second trial called Neo Mindset trial. What they did is that what if you now, same type of trial earlier, take the aspirin out, but now these are the all acute coronary syndrome patient, not low risk, all of them. So we wanted to, have been some data earlier showing that acute coronary syndrome, you stop aspirin, may be bad. So this is same thing happened, monotherapy, take the aspirin out, compared to continue DAPT in large number of patients, 3,400, and you see that half were, 61% were STEMI, 31% were non-STEMI and then unstable angina, rest show here. And what did they find? Basically, that by taking away the aspirin, which is the monotherapy in blue, compared to DAPT in red, you start having a little trouble. So trouble basically means the event rate. First thing you had to do in all these trials, you need to understand, ischemic endpoint cannot increase. And most of the trials, ischemic endpoint were similar, and the bleeding difference happens. So this here is a little different. As you can see here, that now ischemic endpoint, 7% in the monotherapy, 5.5% in the your DAPT therapy. So all cases, low risk, high risk was a trouble, and this is actually death, MI, stroke, and you see the event rate. And the bleeding, yes, bleeding was lower with the monotherapy, that clearly was, but they were at a risk of slightly higher incidence of the MACE endpoint. MI rate, 2.7 versus 1.9. It's a little higher and so. So then third trial, and I'll put them all together. Third trial was that what if we, the tailored chip trial design, what does that mean? So we say that conventional, continue clopidogrel aspirin, patient with a complex high-risk PCI, but now we want to change. And change basically is that change to low dose after the PCI, that you change to low dose ticagrelor plus aspirin, 0 to 6 months, and after 6 months, give clopidogrel alone. So they have very complex design of the trial. The 60 milligram, because these were done in Korea. Korea actually, they have done pharmacology studies before that 60 milligram is good enough. You don't need to give 90 milligram of ticagrelor. And they have shown that from their earlier small trials. And here basically was that what if you tailor that's aggressive in the beginning, then de-escalate after 6 months. And so the little complex design, but trying to see what could be the better combination, and found it that your tailored antiplatelet therapy didn't help much compared to the DAPT. As you can see here, again, height of the red bar, so no additional advantage came, and rather it caused more bleeding. One, no benefit of ischemic endpoint and caused more bleeding. So what good is? So again, this trial failed. Then there's another trial, was in the dual ACS trial, that should shorter duration of therapy be used after MI in Sweden. It was not 1 month, 3 months. And remember the Twilight trial done by Roxana Mehran was 3 months, 3 months of aspirin and ticagrelor. And after 3 months, aspirin was dropped in one group, another one, both were continued. So 3 months, not 1 month, and 3 months, this was 3 months versus 12 months DAP. And you can see all ACS patient, 23% on medical therapy, 71% PCI, small number had cabbage, and the trial was terminated because of COVID impact and low recruitment, but basically showed that overall from the cardiovascular death MI and point of view was no difference, and of course the bleeding was slightly lower, p-value of 0.097. So key is a plus minus trial, but all showing that 3 months was okay, not a clear-cut benefit, but trended towards benefit overall in the short duration. So mixed message, and I'll try to put it together a little later. Then the colchicine in acute MI. Remember last few years, we have done many trials of the colchicine and all showing that colchicine is good. Colcott, Lodoco, then meta-analysis became the class 2A recommendation for European Society that every aspect colchicine was good. Then another major trial was done called Clear Synergy. Basically patients, it was 2x2 factorial design trial of the colchicine spironolactone. The patient with the STEMI getting PCI and starting colchicine 0.5 milligram daily, and of course within 72 hours. And of course, they got a spironolactone versus placebo, so 2x2. Our interest is only with the colchicine group. I know spironolactone group did not have any difference. So two aspects. Colchicine is anti-inflammatory, which has been shown that it causes lower CRP. Answer is yes. Colchicine decrease the inflammation, what it's supposed to do. Second, did it change the outcomes? Now, 5-year data, no. All of a sudden, now the pendulum swung on the other side. All trials of colchicine were positive. All of a sudden now major trial with a long follow-up, no benefit. We are talking about 7,000 plus patients of the STEMI patients, and individual endpoints are shown here, and that absolutely no difference. Then they went to the individual, hazard ratio on the predefined endpoints. The one point really came up that if some patients actually, they gave those who wait the once daily versus twice daily, that patients who were overweight, more than 70 kilo, if you give twice daily dose of colchicine, was slightly better. But again, this is sub-analysis, but colchicine caused more GI side effect, so overall trial became very negative in terms of. Now, question is why? Why this happened? So what happened is, one of the effect, it caused the tubular formation. That's how colchicine basically work at the early level. But it turns out to be, once you have done the PCI, the colchicine inhibit the vascular endothelial growth factor. And that is required for endothelialization. If you do with the STEMI patients, it was a negative trial, and that seems to be one of the factor, and less endothelial proliferation. But the field has not stopped yet. There is another trial with the plaque volume change by giving colchicine. That does it decrease the plaque volume and CRP? Answer was yes. A small trial, about 60 plus patients. CRP level decreased by giving colchicine, but also the total plaque volume, atheroma volume decreased on the CT by giving colchicine. That was the X-From trial. So see, this field has not stopped. I'm sure there are some other, you will hear more about it in the future about the colchicine, but I can tell you that clinically, when we start using, because of it, a lot of data showing with those trials, clinically I did try in few patients, but did not have a good outcome of the colchicine. Now, FFR trial, which is the physiological trials, one of the major trials, you remember, a few years ago we presented, FAME3, which compared multi-vessel disease, FFR-guided versus CABG, and basically showed that 1 year CABG was superior to FFR-guided PCI. Then we have 3-year data. Now you have kind of p-value of 0.07. And now they presented this year 5-year follow-up. And you see 5-year, that seems to be the curves start converging. And now no longer significant. You see the p-value, hazard ratio become 1.16, and the individual endpoints are no longer different. Particularly the death, the combined endpoint of the death, MI or stroke was no longer different, but we clearly know the repeat revascularization and MI was lower with the CABG group compared to PCI. But just to say overall, it looks like that once you get to 5 years, the real benefit of the CABG decreases at follow-up. And it was more so we know that simple cases do better with PCI, complex cases do better with CABG, remains with this trial. More importantly, what I want to show here is how our science has improved. Look on the left side, the Syntax trial. Multi-vessel disease complex, that time we compare Texas stent versus CABG. Event rate was 14.6 in the PCI, 9.2 in the CABG. And guess what? In the FAME3 trial, 5-year follow-up, those are the cohort patient, 3-vessel disease, not much difference in the baseline, but look at the event rate, how good we have become. Revascularization, whether it's a CABG or PCI. And same way, in terms of the mortality, death, MI, stroke, all combined have been a lower. So left side was only death, right is to say that intervention, whether surgical or our percutaneous, may be part of the multiple aggressive medical therapy with the statins and with the SGLT receptors to have overall improvement. In the past, we used to have a cutoff of 22. Then one of the trials showed that 24 may be a better cutoff in terms of the PCI versus CABG difference. There was an acute MI trial, Flower MI, FFR guided versus angiographic guided. You know, FFR is used in the otherwise, but in the acute MI, the trial showed no difference, even up to 5 years endpoints that FFR guided was no difference in angiographic guided PCI in various outcomes. So the acute MI setting, FFR is of no additional use. Then question comes is clopidogrel versus aspirin post PCI long-term trial. Patient has been 1 year done, DAPT 6 months, 12 months, 18 months. Now question is which agent you stop. Many people stop the aspirin. Many people stop the clopidogrel. Now we actually have the answer to this because we have 2 trials. This is a smart choice trial, again from South Korea. Basically was that if you have completed your duration of the DAPT after PCI, so take away continue either aspirin or continue clopidogrel. That was the answer we needed. Which one will be better? To follow these patients, 5,500 patients, and basically see that clopidogrel with the primary endpoint was almost the 30% decreased compared to aspirin. And the bleeding was just non-significant, but most important is that primary endpoint, so clopidogrel was superior to aspirin at follow-up after completion. And the individual endpoints also showed that particularly patients with a high bleeding risk, diabetes, and so clopidogrel was better. And most important, we always have been teaching the stomach gastrointestinal point of view. Aspirin gives you more GI side effects, which are confirmed with this trial compared to clopidogrel. So anytime patient has the GI side effects, stopping the aspirin is better than clopidogrel, we learned from the trial. This is actually extension of a trial, an earlier trial called host exam trial, which showed the similar benefit that stopped after your 12 to 18 months of DAPT. Clopidogrel did better, and even the complex cases, patients with high bleeding risk, all they were superior by stopping the aspirin. I mean, compared to aspirin, clopidogrel was better. So you can make it a point that patient now continue long term. You need to decide with one antiplatelet therapy, probably clopidogrel is better, and it's better for the stomach point of view. And the lastly was our guidelines. We actually, after a long time from our ACC or the European, they keep upgrade every year. So guidelines came, both of them 224, European guidelines for coronary syndrome. You know, old stable angina, now we call it a chronic coronary syndrome, and acute coronary syndrome is ACS. So ACS was our ACC guidelines, and they basically went through various, simple way, mechanism of myocardial infarction, how you take care of these patients, particularly the CCTA, which we have been doing quite a bit, coronary, not just the calcium scoring, but coronary, the computerized CTA has been kind of level 1 indication, or at level in majority of these cases when you suspect CAD. And of course, many of the cases you can directly go for angiogram. You don't need to do any test in between. Lipid lowering, very important, that bring the LDL to 55. That has been quite a bit. And the patients also with they have various lipid levels. The last basically was 55. Now they actually just last month also came up with a focused update on the lipid and saying that maybe you should go down to 44, less than even 55. So even in extreme risk patients. So now 55, 40, because all the trials have shown lower the better, and we're requiring additional agent to get to that level. Now others, what the new guidelines basically was that complex cases should have heart team discussion, imaging I already mentioned, and lastly is the patient choice. We as a physician have to offer to the patient that this is the right thing to do. Patient can decide after whatever the discussion with the family, but you're not making the decision while patient lying on the table. Has to be outside. And that the patient is the final decision maker. And we actually have published also, we do that routinely, that almost 45 to 48% of patients where we recommend should go for cabbage, they'll decline cabbage and will come back for PCI. But that's okay. But those do have a little higher risk compared to those who are otherwise would have gone for appropriate PCI. But they're not surgically inoperable, not surgically ineligible. They just decline cabbage. They do have slightly higher risk, but this is what our practice is, and that is ultimately they're given to the kind of patients to make a final decision and so. We have talked about this already. They also emphasize quite a bit on the chest pain in the normal or non-obstructive CAD called ANOCA. Very common disease process. Patient coronaries are normal, comes back, we say, be happy. Patient continues to have chest pain. He said, no, you should be investigating those patients. And this actually a lot of emphasis on ANOCA and INOCA and functional testing. And this led to our second month of the CFT coronary functional testing with the Sweeney and Moreno as the moderator, which is happening first Wednesday of every other month because so much demand to really identify and understand that why these patients have chest pain with a non-obstructive CAD. Then antiplatelet therapy, they have gone through what we do it, acute coronary syndrome, 1 to 12 months, stable syndrome for 6 months and so. Also importance was that adherence of the healthy lifestyle. Lot of focus on individual endpoint, that not only what we finished in the cath lab. In order to improve their long-term outcome, these patients have to follow subsequently in terms of medical therapy, their healthy lifestyle, keeping the risk factors too low. And basically from the ACS point of view, our guidelines is about the same, most important being that the invasive angiography in various group of patients with the ACS and non-STEMI is kind of you can justify in all, but in the low risk patient it's okay if you can just decide based on the watch the patient, and then you decide if patient fails some subsequent treatment or stress is positive, then do the angiogram. But doing angiography is still okay in majority of the cases. Only second question was, do you do right away within 3-4 hours or do it next day or so? It's a class 2A that you can do angiography within 24 to 48 hours in these patients. The second was patient which we have learned, that patient which I mentioned earlier, that full patient multivessel CAD in STEMI patients, that you do full revascularization, all culprit as well as non-culprit. And the second point was when you should do it. They do say that preferred over the PCI at the time is preferred compared to a stage approach. And because remember, 2 trials showed that event rate was higher. But we actually don't notice that. But key is that don't wait too long. Just after a few weeks, it's completely fine. Then also the patients who are STEMI, particularly with the cardiogenic shock, you do only the culprit vessel, not the full vessel revascularization. The statin guidelines are about the same. The depth discharge, this is actually credit goes to, again, the Twilight trial by Dr. Roxana Meran, that after they became the class 1 guideline now, that after 3 months, you can stop aspirin, as long as you are giving ticagrelor monotherapy. This is not for clopidogrel, because that was not tested. It is ticagrelor monotherapy, and otherwise it's a 6 months for a stable patient and 1 year for same. They also have a lot of emphasis on cardiac rehabilitation, all-cause mortality, reduces readmission, and cost-effective through exercise, education, psychological support, and medication optimization. All those are very important for the work. We finish it in the lab. So this basically puts it together. Advances in anatomy just completed now. Basically, give the message that what we learned, how the practice is changing for this. What we learned, ECMO and balloon pump and cardiogenic shock, rotablation for ISR, drug-coated balloon in large native vessel, and colchicine acute MI. No good, no benefit. FFR guided or maybe even harmful some. FFR guided PCI in multivessel CAD, STEMI, P2Y12 monotherapy in acute coronary syndrome or tailored DAPT, which was there. OA, orbital atherectomy or laser in calcific lesion, no good. Then FFR guided PCI over CABG at 5 years, same trial. Stage versus immediate complete revascularization multivessel STEMI. So don't do immediate. If you need to do, stage is better, because elderly patient, heart failure patient, they do better. So we rarely will do, that has been our practice. We don't do multivessel on the same day. Either do that day or stage. The question still, in my opinion, remain, stage should be on day 3, which will increase the length of stay in America, which is very important, or you bring back after a few weeks. So I think our policy of staging after a few weeks, as long as patients on good medical therapy, although 2 trials did show, while you are waiting for the stage, they had a higher revascularization and higher MI, but I don't think we have seen that. Then aspirin withdrawal in low-risk MI, which is okay, and 3-month versus 12-month DAP post-PCI is good at present, and right approach. Then Impala in cardiogenic shock, IVL or rotational atherectomy in calcific lesions, clopidogrel or aspirin, long-term PCI, long-term after post-PCI, 2 thumbs up. And then the DCB in ISR and side branch, imaging, OCT or IVUS in a complex lesion with plaque modification guided PCI, and then of the European as well as our American guidelines in the PCI in chronic coronary syndrome and ACS really helped us to navigate our treatment strategy for many of these patients. So how do we put it together? If I give you our numbers, what has happened? Our Impala use was 95 in 2022. At this year, we'll probably use 118. So clear increase. Orbital atherectomy and ELCA use, 5 to 3% used to be in 23. Now we have 1 to 2%. Clear decrease based on the trial, that's what our practice has been. Our intravascular imaging used to be 15% in 23, and it's to 33% at this time. Should it go a little more? Probably can go to 40, 45, because remember, the guideline of class 1 is for complex lesion, bifurcation, long lesions, and so. Not in every case, and maybe in some acute coronary syndrome. Then DCB use for ISR, of course, it was not available, used to be 1%, now it's about 10%, largely because we are part of the many trials, not because we are using clinically, but because ISR patients are in the trial. Then IVL use, which is the shock wave for calcific lesion, 8% in 23, now about 14%. Definitely has improved. The guidelines have changed our interventional practice to improve patients' outcome. This actually showed still the old slide, but just to say our superiority in terms of volume and the safety compared to other the medical centers here. And then the CCC live webcast, which is now every week we have. The first used to be coronary only, then we use endovascular, then we structural, they all once a month. Then every other month we added now our microvasculature as well as the imaging. So all 4 weeks there is some live webcast happen, and that actually has been very successful with the 22 to 25,000 hits per month. And United States and India actually are the top in that group. But that's really has helped, I would say, the extending our educational mission globally in 176 countries, which is added by the largest, of course, ACC app are tremendous, but from any one institution already, only interventional, the apps is all done with the Kini and her team. Every aspect of interventional cardiology has translated into some kind of app. Right now, I think 14, and then many others are coming. Purpose there is just to educate others, also those who may not be up to date with the latest data, by updating even these apps. As you can see, there is bifurcate, then bifurcate 3D. So we keep changing, then Angio 8 3D. So all these continue to change and upgrade the overall educational mission of Mount Sinai Fuster Heart and Cardiac Cath Lab, to educate more people, to make them better, improve their own interventional practice, to improve the overall outcome. With that note, I'll stop here, and thank you very much.